So this is something pretty new in our country, but even world over, the acceptance seems to be growing. So let's see what we are going to talk about. I must thank Dr. George for making a great introduction. So this is what we clearly know, that LDL reduction leads to reduction in atherosclerosis. And there are so many studies from maybe last couple of decades and more, they have shown this kind of response. So statins are most important tools for prevention in cardiology practice. And there is almost 21% reduction with each milliosmol reduction in LDL reduction. However, this hasn't brought the risk down to zero, so we need to go beyond statin. So we keep combining statin with ezetimibe. There are many other therapies which are sort of work to some extent, follow to some extent, but this is the new kid on the block, and let's talk about this. So it's not that it was invented yesterday. It's been going on for almost 15 years, but the US FDA approval actually came in 2015, and the Indian approval came in 2017. So it's just about 2 years that we've been using this. Now, this is actually a drop in studies with ezetimibe, and you can see that Evolocumab has a bigger drop compared to ezetimibe. So adding ezetimibe to statin and adding Evolocumab to statin is a big difference. The PCSK9 is a regulator of LDL metabolism. And we know that the LDL actually gets linked to the receptor, gets into the cell, and it gets degraded. So PCSK9 works here. And if we inhibit PCSK9, the LDL is available back to us for picking up more LDL. And this is how the PCSK9 inhibitor can bring down the LDL value. So this is a fully human monoclonal antibody against PCSK9. It blocks the PCSK9 LDL interaction, and thus the LDL reduction is very drastic. The important thing is the duration. The half-life is 11 to 17 days. And as you heard earlier, the 120 milligram dose can be given as every 15 days based on this. So 2 times a month. So you have 140 milligram given once every 2 weeks, or 420 milligrams given once monthly. For familial homozygous familial hypercholesterolemia, we have 420 milligram once monthly. This is something which is very difficult to treat, does not respond to many other therapies, and that is why a bigger dose, but luckily just once a month. When we ask, should we combine it with statin, the answer is yes, because as you can see here, the combination therapy is superior to monotherapy. So always combine on a good dose of statin, additional Evolocumab. In statin intolerant patients, however, you can use Evolocumab as monotherapy. So this is a clear option for people who do not tolerate statin therapy due to myalgia, renal impairment, and hepatic impairment. Fourier was a huge study, 27,000 odd cases, where Evolocumab 40 milligram twice a month and 420 milligram once a month was compared with placebo. And you can clearly see a huge drop in the LDL values. Now you must have figures which show an improvement. This is very easy to observe on a lipid profile, but you must have this translate into cardiovascular benefit. And this is what is seen in Fourier, that cardiovascular deaths, MI, stroke, clearly were less with evolocumab. So LDL dropped, and you also have a drop in the event rate and the primary endpoint. Now, this is a question which was asked earlier, whether we should continue beyond 1 year. The answer again is yes, as you can see here, that the benefit beyond 2 years actually is getting broader and broader. So you not only initiate, but you initiate and continue it for a longer time. And this is what is shown here, that the benefit continues if you go for a longer time. And then again, when to start this after a coronary event. So if you start inside 2 years, the benefit is much more than if you start it for a patient who has had an infarct 10 years back. I'm not saying that don't give it for somebody who's got an infarct many years earlier, but then benefit is bigger for somebody who is in front of you, and that's why you should initiate this therapy as early as possible. As we heard earlier, if you initiate in hospitalized patients, so many times the insurance companies also give the reimbursement. Also, people get a bigger benefit in those who have had more than one infarction. So people who have one infarct probably have a smaller benefit compared to those. All that it tells me is higher risk patient who is getting multiple events must get this molecule, and that too as early as possible. Also, people who have multivessel disease, again, they have a clear bigger benefit than no multivessel disease. People who have diabetes clearly show a bigger benefit. Diabetes event with or without diabetes, both show benefit, but I guess the diabetics will continue to show a bigger benefit. Now patients with diabetes are a substantial higher risk for CV events, and evolocumab is efficacious in ASCVD patients with or without diabetes. Now many people worry about low or very low levels of LDL, and you already heard some questions about neurocognitive dysfunction, but it is shown here, and you should feel it safe that those who had LDL less than 20, this is LDL less than 20, well, this is less than 100, even then the neurocognitive dysfunction is not statistically different from each other. So the worry that statins lead to neurocognitive dysfunction or low LDL values lead to this kind of dysfunction should not be there. I think this is what most of us would like to follow, the Lipid Association of India 2016, and here we have LDL values which are should be less than 50. The ESC as well as AHA, they continue to take 70 as a guideline. But we as Indians, though we feel proud that we are Indians, are at a serious risk of diabetes, serious risk of coronary disease early in life, and that is why we should target LDL at 50 instead of 70. I think I showed this slide in the earlier talk, but familial hypercholesteremia for children who have less than 135 for children, this should be our target. For adults, 100 should be our target. And those who have events, it should be 70, as I mentioned, In Indians, it should be 50. This is again showing you that there was no increase in the neurocognitive effects with PCSK9 antibodies. Some of the patients have got LDL values going down below 20, and you're obviously worried that it could lead to something, but it is found to be extremely safe. Also, the statins and PCSK9 statin and PCSK9 have synergistic action, and that's why the PCSK9 increased level are strongly blocked by the PCSK9 inhibitor, the Evolocumab, and thus we get a strong reduction. The impact of PCSK loss of function mutation on risk of MI, you can clearly see in all these studies there is a clear benefit with PCSK9 inhibitor. So let's sort of conclude that higher risk the patient, higher is the benefit, but you must use the correct medication to achieve this kind of drop in benefit. If you do not, the higher risk continues at high risk and would keep on getting events over a length of time. And who are these high risk? You have ASCVD with diabetes. You have ASCVD with CKD. The incidence clearly increases if you have diabetes with kidney disease and atherosclerotic coronary artery disease. If you have a less than 3 months recent ACS, again the risk is very high. And if you have a combination of coronary disease and a peripheral vascular disease, the risk of event is clearly higher. So highest benefit is seen in highest risk individual. So this is something, a strong tool. You have to use it effectively, but you cannot generalize and use it like statin because it's very expensive. So you have to sort of choose your candidates where you're going to use it. And who are these candidates where you would like to use Evolocumab? Patients not reaching statin goals. Almost 56% of statin-treated patients are not at goal, and especially true in high-risk individuals where even 60% and above are not at risk, and in moderate risk patients, almost 34 are not at risk. So all these patients need something stronger, and as we discussed earlier, ezetimibe is one reasonable weapon that we use, but we need to go beyond. So these are a kind of statin non-responders. Then we also have statin giving side effects, the statin intolerant patients. So these are the ones who have severe myalgia. Some of them, of course, have CPK rise. Many of them will have kidney-related issues, liver-related issues. So all these monitoring shows that these are statin-intolerant patients. We have a stronger tool available now. The target population, therefore, should be patients with inadequate response in bringing down the LDL due to whatever reason. Then CV events despite high-dose statin or maximally tolerated statin dose. People who have diabetes and ACS population are at a highest risk. And luckily for us, we have always moved from this, high is bad, then we thought average is not good, lower is better, then even lower is even better, and now we talk that the lowest is the best. So we have a very strong tool which can get you down, your LDL down. Now this is a typical diabetic case which goes over a length of next 20 years. In 1997, inferior wall infarct, angio done, very distal block, left for medical treatment. Patient in 98 had effort angina, and then a repeat angiogram was done. The block, in addition to this, extends. So patient has remained stable for 10 months, but from 11th month onward shows this kind of symptoms. and obviously something is going wrong inside his coronaries. So at this stage, we do a balloon angioplasty. In '98, we didn't use long stents, which is an option today. 2 years later, in addition to his, the artery is open, whatever we had done. But in addition, he develops a proximal block and a sizable block in the left coronary system. So in between, in 2000, 2001, 2003, he was having stress test, which was mildly abnormal. But since these were abnormal, we did a thallium. So what I'm trying to say, a diabetic patient must be followed at regular interval, especially diabetic with coronary artery disease, because there is sort of built-in tendency to advance into coronary disease. So in 2003, he underwent bypass surgery. Typically, we give all arterial grafts or diagonal LED on one Lima graft, and the Y, which is giving a graft to OM1, OM2, and the PD of RCA. So 5 grafts, this patient was good for next many years. And in 2011, that's about 8 years later, he comes back to us. So that time, this portion of the graft is blocked, this portion of the graft is blocked. So only this graft was patent, and this portion of the graft was patent. So we had to do angioplasty to the totally occluded right coronary artery, and we also worked on the left system to do a left main OM stenting. A couple of years later, he had a TIA, so indicating that he had a cerebral event. The ICA showed 50% block, conserved and kept on medical treatment. 2015, 3 years later, his ABI was abnormal with some leg claudications. So we decided to conserve both of these. But by 2016, patient decided that he will conserve himself from all the procedures. But let's see what his LDL is showing. 138 in the early years, 97 when he had the first episode. And with rosuvastatin, we had some kind of benefit coming down to by about 40 degrees. But however, the disease is progressing. His coronary events were happening again and again. He had a brain event, he had a leg event. So disease is progressing all the time. And you can see it right up to 2017 when the FDA, Indian FDA approved Evolocumab or Repatha. He was above 80. We have used all kind of combination known to you and I up to this. And you can see we dropped to 50 and less than 50 in December last year. So this is a molecule which is very potent, and therefore it's allowed in all the ASCVDs. It's not that you should keep it reserved for rich patients. Rich patients having progressive disease, of course this is an option, but it is going to be very effective for familial hycholesteremia and those who are at high risk for coronary artery disease. I'll just end up with one case, age 29, inferior infarction, age 42. This was actually an inferior infarction. We put a stent in the right coronary. At age 42, that is about 13 years, left system was very normal when he was 29. Advanced disease, we put 2 stents, including a covered stents. For age 49, he has a critical disease at the ostium of the circumflex and also left main. So from 29 to 49, he's not diabetic, but just that the disease is progressive. One should strongly think of a familial hycholesteremia. And even here, we had some drop in LDL with atorvastatin, but still, when he got the second event, we are still at 97, which is clearly above what you and I want. And he was all the time on 80 milligram, and only now with Evolocumab, we are getting a figure of 42, 49 and 42 recently. So if we are going to keep LDL like this, I'm sure somebody who gets it young is going to really benefit. He's fully functional, left ventricular function, ejection fraction is normal. The last 2 procedures actually we did was much against our sort of desire. We had recommended bypass surgery, but he didn't want. So most of the major guidelines, they recommend evolocumab under indications which we saw. But clinical ASCVD not responding to statin becomes a very strong indication. We also must understand that just because it is expensive, many people ask, yes, I will take it, but for how long? The answer is going to be very long, maybe lifetime. Obviously, the answer sets them back a bit, and some of them may say no. But you and I know that if somebody is going to get a coronary disease at 25 and 30, and if you want to take them to 75 without procedures, I mean, yes, bypass, angioplasty are options, but they are sort of support. You have gone off the track, they can bring you back on the track, but we need a tool like this which would definitely help us. So evolocumab probably has very strong support from Fourier data, 27,000 odd cases. There are some other molecules also which are coming into pipeline, and today actually we have only Repatha as injection available to us. That too 420 milligram is not available. We have 120 milligram. So you use it twice a month. And cost is a big issue. One injection for an Indian patient could be close to 19,000 rupees. But there are various deals. You can sort of use them conveniently for truly deserving patients. The good thing is there is no rebound rise in LDL. Sometimes patient cannot afford, or for whatever reason he thinks we should not take it. But even if you stop, there is no rebound LDL increase. So that's a good news, and patient will continue to benefit. The approval for India was in March 2017. Personally, I've been using it immediately after the FDA India has approved it, and we had some outstanding results. So currently in year 2 or year 3, what we are seeing is a drop in LDL. The true benefit in terms of event we'll probably see after 5 years or after 10 years for a young Indian diabetic who is riddled with multiple blockages time and again. Thank you indeed for your attention.